year. Presently, she is an assistant professor in Government of Omandurar Medical College in Chennai. So, Dr. Aishwarya, you can start, please.
Good evening, everybody. A 35-year-old IT professional by occupation was presenting with chief complaints of severe pain in the lower back, buttocks, and more on the left side, radiating to the left foot. The onset of the pain, she started after she slipped and fell down flat on her back 3 months ago. Initially, it started with diffuse pain in the lower back and buttocks, and then gradually progressed to involve the left posterior thigh. Sharp dragging type of pain of severe intensity of score 8 by 10. It was radiating up to the left sole of the foot towards the great toe. There was no history of night pain. It was aggravated by standing and walking. It was relieved by sitting, lying down, and forward bending. There was no associated tingling sensation or shooting pain, and there was no recent onset of numbness. Past history, she had a history of fall from 15 feet height at her home 7 years ago, and D11 to L3 posterior stabilization and fusion was done for L1 burst fracture and cauda equina compression. Post-accident and surgery, she had weakness in the left lower limb for which she underwent physiotherapy. Since then, she has numbness and tingling sensation, and she can feel the skin tightness over the entire lower limb, more in the thigh. She has history of depression for the past 7 years and is on treatment. She has no other history of diabetes, hypertension, or hypothyroid. Personal history. She takes a mixed diet. She's not an alcoholic or a smoker. She has no complaints of sleep disturbance. Treatment history for pain in the lower back on and off. She gets treated with NSAIDs and muscle relaxants. Psychosocial history. She has history of depression and bipolar symptoms and is on lithium therapy for the past 7 years. She has a good family support. There are no significant relevant family history. Occupational history. She sits 8 to 10 hours in front of the laptop. General examination. She is well built and nourished. Her BMI is 30. She's conscious oriented. Her mental status was stable. Vitals were within normal range. She assumes a mild stooping forward posture when she's relaxed. And the gait was also not normal. She was slightly leaning towards her right. Examination of the spine. On inspection, there was previous surgical scar in the midline of the lower back. There is no apparent wasting of muscles and there's no skin color discoloration or changes. The range of movements, the flexion was normal. Extension was partially restricted due to pain. Lateral bending and rotation was also partially restricted, and it was more on the left side than on the right side. Palpation, there was no swelling or raise in temperature. There was no tenderness in the midline. Bilateral or SA joint tenderness was also not there, but the tenderness was there in the bilateral paraspinal area, and again left side was more than the right side. And there's no allodynia or hyperalgesia. Examination of sensory system. Right lower limb, touch, temperature, vibration, proprioception, pressure, everything appeared to seem normal. The left lower limb, she had hypoesthesia in the anterior thigh extending up to the leg. And the touch sensation was also diminished in the posterior thigh, but it was comparatively better when compared to the anterior thigh. Examination of the motor system, the right lower limb, right hip, knee, ankle, great toe, the entire range of movements were of 5 by 5. Left lower limb, there was mild spasticity in the anterior thigh. Left hip flexion, extension, adduction, abduction, everything was 4 by 5. Knee flexion, extension 4 by 5. Ankle dorsiflexion and plantar flexion, and great toe flexion and extension was 5 by 5. The examination of the reflexes, the deep tendon reflexes, right knee jerk, ankle jerk were normal. Left knee jerk and ankle jerk were normal. Special tests, the straight leg rising test and the reverse SLR were all normal. Facet loading test was positive on extension and lateral bending, again left more than right. The stoop test was positive. Bilateral Faber and fat tests were normal, and there was sacral thrust test was negative. Investigations were done and the blood investigations were within normal limits. This is an MRI report. That's all.
So, Dr. Aishwarya, you are essentially saying that initially she had a fall and she had some symptoms then, and she had a fusion surgery for that segment. And now she has come with a fresh left-sided radiculopathy of 3 months duration. That's what you're saying.
Yes, sir.
Right. Okay. So your symptoms are the initial symptoms were more along left L2, L3, and L4, and the ones that you're saying now are more like L5, S1, something like that.
Yes, sir.
So yeah, the MRI you can put it in the end, so all of us can watch the MRI. Can you go back to your first history, please? What's her complaint right now? So we have a 35-year-old female
with pain in the back, lower back,
buttock,
and radiating towards the left foot. She says it's there towards the from entire posterior thigh towards the left foot.
So basically, that anterior left leg anterior pain has been there for some time, and that's okay. She has come mainly with this pain now. This is her complaint now.
Yes, sir.
So please make this history very clear that the which pain was there since accident and which pain is completely newer in onset. That is not very clear in this.
Okay, so sir, initially there was no pain and there was only major numbness in the anterior thigh. That's what she said, sir.
Okay. So pain is not there in the anterior and the anterior aspect of the thigh and the other part. So yes, pain has started only on the posterior posterolateral part recently of 3 months. Is it right?
Yes, sir.
Okay. Okay.
Okay. Panelist Ravi, was Ravi there? I just saw Ravi.
Yes, sir. Good evening, sir.
Good evening, Ravi. So where do you think this is going? Now, there is a history which is 7-year-old, which the patient seems to have recovered from. And there is a history which is 3-month-old for which she has come. So where do we think we are going with this in terms of diagnosis?
Multiple differential diagnoses can be there. So the most important ones which I am thinking is one is the refracture can be there, wedge compression fracture. Second thing, the lateral canal stenosis. The pain is more on walking. So this can be there. Then the third thing which she felt ki the pain is also on buttocks and also on spine. So facet component is definitely there. So along with this canal stenosis, facet component we can add. Then the next thing, one more differential diagnosis can be this piriformis syndrome, especially the pain over the buttocks. So she is complaining of. And then one of the most important thing we would not like to miss is this the persistent post-spinal pain, the failed back surgery syndrome we are talking about. So these are my priority differential diagnosis, sir. Back to you, sir.
Thanks, Ravi. This Dr. Aishwarya, can you go to the MRI film now? I think the second last slide was your MRI film. Ashok, sir, you're there?
Yes, I'm there.
Yes, sir. So we have a patient who is a 35-year-old lady who had a previous spine issue, and then presently she has come with a 3-month history of again left-sided radiculopathy, but this time, according to the history, the symptom seems to be more along something like L5 S1 dermatome, so posterior thigh buttock pain. So how do you think we should approach this, Ashok?
Yeah. Presently, she is having a sort of a complex presentation, I would say. Part of presentation may be new in onset, and also part of it may be a continuity of the previous injuries or insult to the spine, which has occurred in the past. The presentation of the symptoms also, they are a mixed presentation which suggests a radicular component and also the facetal component. And these radicular symptoms may be new in onset, though the fibrosis they have not talked, but could be a part of fibrosis which might have had happened with such a long implant patient is having from L1 to L3. So to me, she looks like that what MRI is suggesting of alpha S1 disc. Also, the facetal hypertrophy at 3-4 levels is now becoming a presentation in this particular patient. So as you ask me that what are the possible causes of the pain, so she has the dual factors for the pain. One is disc origin from alpha S1 and from the 3 facetal hypertrophy, and also the component of additions in the spine. To you.
Right, thank you, sir.
Karthik sir, one thing via this MRI, we can see this. There is a clear L5S1 disc, and also at post fusion surgery, there is a dural sac compression over this higher level at L1, L2 level. So these two differential diagnosis means the initial.
The present complaints for which she has come is left buttock pain, posterior thigh pain. So that is not L1, L2, L3. What the symptom that she is saying right now is more left L5S1. Is that correct,
Yes.
Aishwarya?
Yes.
Yes, sir.
So, Dr. Aishwarya, did you check the power of this great toe, EHL power?
Yes, sir. That's normal.
That's normal.
Normal, no? Okay.
Right. Palak, are you there?
Yes, sir. Yes, sir.
So, since we have a confusion in level, for the sake of the juniors, can you explain to them when you will do a normal SLR and when you will do a reverse SLR?
I couldn't get you, sir. Confusion in the?
Since there is a confusion in the level, so the MRI is showing some lesion in L1, L2 as well and L5S1 as well.
Yes.
So
sir.
clinically, when you will do a straight leg raising test normally and when you will think about a femoral stretch test?
So your voice is not, when you'll do straight leg raise and?
Femoral stretch test. When will you do a femoral stretch test?
Sir, I did not get your question, sir.
Ravi, when will you do a normal straight leg raising test? When will you do a femoral stretch test?
Am I audible, sir?
We can hear you.
So there's some problem.
Okay, Palak, you can relax. Ravi, can you take that question?
Yes, sir. I'm here, sir. Yes, sir.
When will you do a normal straight leg raising test?
So whenever there is suspicion of a radiculopathy, especially in the cases of PIVD, so we are going to do this SLRT test. So in the cases of the radicular pain unspecific to means origin, like if we are not talking about disc pain, means the PIVD, so then we can go for this this tripod test or femoral stress test, especially. Means non-specific to this nerve root compression. In those conditions, we can go for this femoral stress test, sir.
Which nerve roots you will be testing in the femoral stretch test?
Sir, especially the sciatic component, sir.
So, Karthik, I'll be requesting you for the all the juniors and the this.
Okay.
Can you
Yes,
explain exactly the question what you are asking? If you can explain yourself.
Okay, so essentially, when you do a straight leg raising test, you are essentially checking for mainly L5 and S1, right? So what are the rules of the game when you do an SLR? You can do the SLR in supine position, you can do it in sitting position. Now, the take-home point when you do an SLR is you're not looking for pain in the back, you're looking for pain in the leg, right? One. Second is, when you do a normal SLR, it mainly checks components that is arising from L5 and S1, maybe a little bit of contribution from L4. If there is a herniation, like in our case in L2, L3, where the involved nerve roots may be L3 disc herniations, nerve compressions, or L2 disc herniations, nerve compressions, the SLR will be normal. So you have to do the reverse SLR, which is more a femoral stretch test. So If you are looking for disc or nerve root compressions in L2, L3, and L4, go for the femoral stretch test. If you are looking for L4, L5, and S1, go for the normal SLR. One. Second is common mistake is always look for pain in the leg, not for pain in the back. So that's just for the sake of the juniors, right? Now, Joshri ma'am, are you there, please?
Yes.
Nice to see you, ma'am. In terms of differential diagnosis, Aishwarya put up this case where there is an old history of a lesion in L2, L3, and L3, L4, and there seems to be a 3-month history of a lesion in L5, S1. She gave a good clinical examination. So in terms of investigation, is there anything else that's going to add value? Is there a role for a nerve conduction or something like that?
See, nerve conduction studies, in my opinion, most of the time they will say inconclusive at the end. But let's get our goal straight. This patient has an extensive history. She had a prior fracture. Now her symptoms are mostly on the left side. She has evidence of surgery. If you look at the section for L4, L5, you look at the facet as well as the foramen, both are narrowed. Hard to tell whether it is scar tissue only. She did mention in her initial site that, did she say arachnoiditis or inflammation? So anyway, scar tissue is a potential, or a reherniation is a potential cause possibly, along with facet arthropathy. I do not think an EMG is going to add any value, in my opinion. Okay, whatever we have with this imaging is extensive, and so we can decide what we want to do based on our complaints just from this.
Right, ma'am. Thank you. Aishwarya, can you go back to your, you had a very nice pain map. Can you put that on? Dr. Smriti, are you there? Dr. Smriti Rekha?
Yes, sir, I'm there.
So if you look at this map here, this is the pain pattern now. So this is a 3-month-old history. This is the pain pattern now. You saw the MRI, and people are not, I mean, Joshri ma'am is not very keen on a nerve conduction study because she feels this may not add too much information. With this pattern and MRI, what do you think can be a pain generator? What all can be the pain generators?
Yes, sir. As this patient is a post-spine surgery, so I will consider it an epidural fibrosis in anterior and lateral epidural space that may create radicular pain and compress the S1 nerve root. So it's like a sciatic pain along the sciatic along the sciatic nerve distribution. So this could be a pain generator. Facet also can be, a facet arthropathy can also be a pain generator, sir, because maybe due to redistribution of loads, and it could be SI joint also as a pain generator. Maybe piriformis syndrome, it could be also be a pain generator, sir. And disc herniation may compress the S1 traversing nerve root, that may be also same.
Which is the most likely of this?
Sir, most likely, two things is coming to my mind. One is, sir,
So,
maybe due.
Karthik, I'll be pointing on very important things here. What Shruti Rekha was telling, that is right, that a lot of things can be overlapping here. But one of the very important thing here, you see, it is back pain is bilateral. You see,
Yes.
back pain is not only left-sided. Back pain is bilateral, but the leg pain is unilateral, and that is mostly along the posterior side. So this we have to consider. The whole of the back, both right and left. That means why I'm telling this. That means if you are considering only piriformis, that cannot explain the right-sided back pain, because piriformis, it is piriformis back pain cannot be. So what is my thought is that there might be two pain generators together. One is SI joint. It cannot be the whole SI joint cannot explain the other side pain. So there might be the two pain generator, one from the spine itself, which can be axial, which can be both of these things involving. That can be epidural fibrosis, that can be bilateral facet because of the redistribution of the load. Along with that, there might be either sciatic on the left side, either sciatic nerve, or maybe the L5S1 or something like that, which is going to give the radicular pattern. So this is what means. What I'm going to tell that with this pain pattern, only one single pathology cannot explain you the whole this pain map in this feature. So otherwise, either that means either disc, that is another possibility, disc along with the nerve root. So these kind of things, one is causing the bilateral pain and another important component which is causing the radicular pattern.
Right. Okay, so we have a differential diagnosis with the disc herniation being a likely pattern. Facets also may be contributing. There is a possibility of rarer possibility of piriformis syndrome and other things. Now, the MRI is done. Clinical examination, Aishwarya has put very nicely. Nerve conduction study.
Epidural fibrosis can be also producing same pattern. Epidural fibrosis causing the bilateral pain along with the one-side radiculopathy. That is also a possibility.
Epidural fibrosis can be a possibility, but the previous lesion was at L2, L3. Second is it's 7 years post.
The epidural fibrosis, you are right. But what I'm going to tell, epidural fibrosis may not be matching with the exact site of the pain, exact site of the pathology, and the exact site of the, because in epidural fibrosis, the whole thing is very, vaguely losing, tightening of the nerve root, which can be causing. So in that way, epidural fibrosis may not be typical dermatomal pattern. Here also typical dermatomal pattern is not there. Here it is both the foot, upper part and sole, both is involved. That means both the root. So in that way, here also typical dermatomal pattern is not there. So you have to definitely consider epidural fibrosis as one of the very important differential diagnosis.
We can also ask for this gadolinium enhanced MRI and also can see this extent of fibrosis. It might be, sir,
So what I'm going to tell, that is what you are telling, that is true. What I'm telling you, even if the fibrosis is at the upper level, even then that fibrosis also can cause some other areas of the because ultimately why it is happening, it is some pulling of the dura, so that may not be matching exactly with the nerve root.
Yes.
Aishwarya, can you go back to the present MRI, please? The present MRI seems to show a new disc lesion. The previous image, is it, or you showed me? Can you go to the next? Yeah. There seems to be a new disc at 5-1, is it? If I'm right, there is a disc at 5-1 with a bit of inferior migration. So this disc can contribute to, so that is which level, Aishwarya?
I thought it was 4-5, Karthik.
Is it 4-5? I can't make out actually.
I think sacralization is there.
Most likely this is 4-5 with sacralization.
So if it is a L5 and S1 radiculopathy, so this becomes dermatomal, right? So this is matching a pattern, correct? So you assume this is 4-5 disc and 5-1 radiculopathy. Now go back to your previous pattern, the pain map. So this 4-5 disc herniation can explain this pattern, correct? Panelists, did you want to differ with me, or is that okay?
Yes, it can. That is what I was telling that time also when I was talking about the pattern, that the diffuse back pain is because of the disc degeneration, and the radicular pattern is for the nerve root compression. So that is one of the common pattern for the disc herniation. That whole of the back because of the disc degeneration and one-sided root compression explaining the radicular pattern.
Right. So if we want to confirm the diagnosis, any of the panelists would like to do any other investigation or a diagnostic intervention, any of the panelists can take this. Considering we have discussed about 4 of 5 likely diagnoses, to confirm the diagnosis, is there a role for any other investigation or a diagnostic pain procedure?
Karthik, one thing I was going through the cross sections, though it was very small, and I'm getting old, I could understand. I was going very close to see how is the cross section. So the most important thing I was trying to look at the cross section is how is the foramen, which side it is basically herniated more. I couldn't make it out, but that could be one of the very important things to see whether it is matching with the pattern. That you told two things you always match with the pattern to see whether this MRI is matching with the patient symptoms. One is at which level, whether it is matching with that particular dermatome. Another is also side, whether that side, that is very easy things to match, that whether which side is having the herniation more and which side is symptomatic. So from the cross section, I couldn't make it. If Karthik can make it, that is
Aishwarya, can you?
Whether it is matching with the left sided things with the MRI or not.
I think, sir, both foraminas at L4-5 level bilaterally.
I was thinking like that on
it's narrowed.
That's why I raised it. In the MRI, I couldn't find that. Okay, it is only on the left side.
Can you magnify any of these images?
I was searching that. But this image is so small, I was unable to understand whether it is on left sided or it is bilateral. But in the it was looking like a bilateral.
Yeah, it is bilateral.
Yes, bilateral.
So 4-5 disc compressing both L5 foramen.
Then there is a question mark. Then why there is unilateral radicular pain? Isn't it?
That is possible. Unilateral is possible.
That is true. That is true. That is true.
Then comes the role of piriformis. Piriformis.
You have a disc staring at you.
What I want to tell, sometimes in the radiculopathy, radicular pain, MRI is so clear cut. There is almost diagnostic block is not needed. We can straight forward, we can go ahead with the treatment. But here, and this kind of things, where it is bilateral, or it is, sometimes even it is seen that it is more on one side, means more on the right side and symptoms is more on the left side. That kind of also MRI is also possible. And one of the possible explanation is the chemical leakage of the nuclear material, which is irritating more rather than the mechanical compression. So MRI, what we are looking about is your mechanical compression part, but it cannot explain you the chemical irritation part. So that is one of the possible explanation that if it is even it's bilateral, one-sided radiculopathy, which is not exactly matching with the mechanical compression on the other side. But in this situation, when there is confusion, then definitely the diagnostic block is one of the very important thing to rule out the other things. So in this case, I'll be going with a few diagnostic block. One is based on the facet tenderness, facet joint procedure. One is piriformis. So piriformis is also very role of diagnostic block is there, but taking care when you're doing the piriformis, the local anesthetic must not be spreading in the sciatic nerve. And nowadays, most of the times we do it under the ultrasound guidance, so we can take care that our needle is not going towards the sciatic nerve, our drug is not spreading towards the sciatic nerve, because if it is spreading to the sciatic nerve, then diagnostic value is lost. So if you're just relaxing the sciatic nerve, the piriformis muscle, and if you can make it out that, okay, the symptoms is relieved. So in that way, I should, before going to the definitive treatment, we should be ruling out these possibilities. The epidural fibrosis, definitive diagnostic block role is not there, because epidural fibrosis presence does not mean that it is symptomatic, whether it is by gadolinium eminentis, whether by the epidurography, whether by any other test, that it may not be matching with the symptoms nicely. So role of diagnostic block in epidural fibrosis is a big question mark. But for the facet joint, for the piriformis, for the SI joint, diagnostic role is very important. So we can easily rule out these possibilities. Role of SI joint, role of facet joint, role of piriformis. So this can be ruled out with the diagnostic block before planning our management. Okay, Karthik, I forgot to mention. Initially I thought, but anyhow I forgot. In between several phone call came and I was a little bit diverted. So one important thing is, if we are looking, I'm not keeping this possibility at the beginning, but we should be at least considering this part, that when somebody is having a, because see here, the patient from the beginning was having some muscle weakness. That means there was some nerve damage was there. So now, if somebody is having a nerve damage, some root damage or some spinal cord damage, and if it goes on for the longer time, for the years, there might be something like CRPS or something like some neuropathic pain secondary to the nerve damage can develop, which will be not typical, extending to the whole of the leg, which may not be matching and fitting with the dermatome. That must be also considered. Means here is a history where there is some still weakness is persisting, which indicates there is some nerve damage which is still there. So these patients can develop some neuropathic pain in the future, which might not be following that particular root pattern, which might be spreading to the adjacent segment and adjacent sites. So that things also should be considered in the differential diagnosis.
Right.
I forgot to mention when we were discussing about the differential diagnosis.
Right. So, Ravi, if you see a patient like this, so essentially we are left with about 2 or 3 differential diagnoses. So most of the panelists agree that considering now that she's put a big picture of the MRI, and it's fairly obvious that the L4, L5 level, you can see compared to the L3, L4, there is significant disc degeneration. There is obviously an annular tear. The water content is lost. You can see a black disc in T2 weighted image at L4, L5, and both L5 foramen are stenosed. So this is, so now that we have a bigger MRI, pretty much it's staring at your face, even though the other factors are there, including contribution from the previous spine surgery, epidural fibrosis, possibility of piriformis, possibility of facet arthritis. Those things are there, but fairly obvious now that we have this MRI picture that this is coming from the 4-5 disc herniation, which is compressing the left L5-S1 nerve roots. Now, how will you manage this patient conservatively?
Sir, I think she has been already tried on conservative medication for, I think for last 3 months she was on conservative medication. So mostly these patients, we give a trial of NSAID with muscle relaxant for a brief period, say 7 to 10 days, and we keep on extension exercises if there are no neuro deficit, and as the patient is having only a mild loss of power is there. And I think grade 4/5 is there, power in all the lower limbs. So mostly
grade 4/5 in L2, L3, but in L5-S1 it's 5/5.
It's 5/5, yes, sir. So almost the affected dermatome power is quite normal, and one is NSAID muscle relaxant along with this the gabapentinoid group of drugs. So I'll be prescribing with this gabapentin or pregabalin. We'll start with the lower dose, say 75 milligram pregabalin, and then we'll, if the response is adequate or say more than 50%, we'll continue the medication for a longer duration of time, or you can increase the dose of the medication. Second thing about this medication, if it is not providing her adequate pain relief, say less than 50%, so we can go for the interventional mode of therapies. So the NSAID muscle relaxant for initial days, and along with that gabapentinoid group of drugs with the extension mode of exercises.
Yeah, accepted, Ravi. Dr. Smruti, if you are there.
Yes, sir.
What sort of lifestyle change will you suggest somebody like this?
Sir, first of all, I will suggest patient education is the utmost importance. I will ask her the activities though that increases her pain. She should avoid those activities, and she should maintain ergonomics like posture changes and other things like active lifestyle. And she should avoid like prolonged walking, lifting heavy weight. So another things like she should avoid lumbosacral belt mostly. So another thing, core strengthening exercise if possible, whichever she can do.
Okay, so essentially what Smriti is saying is right. So what she's saying is, it's not a great idea for this profile patient to bend forward and lift anything heavy. Usually you suggest them not to lift any weights. If at all they have to lift anything, these patients should not bend down and pick it up. They should squat and pick it up. Second is jerky travel needs to be avoided. Third is ergonomics during work, and you want them to use a reasonably firm bed mattress. So those things you suggest at the beginning. So patient education is important. Like she was saying, not too much role for a lumbosacral belt. So that is acceptable. Now, if this patient, lifestyle changes we talked about and basic medication we talked about, if the patient is not coming around with this, for the latest complaint, that is the radiating pain in the left buttock going towards the left calf muscle, in terms of intervention, which would be a good idea? Dr. Jordan, if you're there. Jordan, sir.
Yeah, I'm there.
Yes, sir.
Just before mentioning a particular procedure for her radicular pain, one point which is not discussed is Bartolotti's. We should not underestimate, like what she is presenting with bilateral buttock pain or the girdle pain in the lower spine, that also comes in a differential of bilateral Bartolotti's. So to rule out whether it is actually because 3 months origin, so is there any active inflammation is going on that a bone scan, 3-stage bone scan can pick up. For this radicular pain, we all know a selective L5 nerve root block will be a diagnostic and clinching point on the left side that this particular root is the cause, not the piriformis or maybe the other similar factors which can cause the radicular pain. So that is my take.
So what Jordan sir is saying is, if this patient does not settle with conservative treatment, his option would be a left L5 selective nerve root block, which includes both local anesthetic and cortisone. So that is his treatment plan. So which is fine. I'm happy with left L5 nerve root injection. Can I ask Das sir, at this point of time, conservative treatment not working, in terms of intervention, would you do just L5 nerve root? Is there anything else would you like to add? What are the other factors you'll keep in mind during interventions in this patient? You're muted, sir. Sir, you're muted. Das sir, you're muted.
So thanks to Jayashree. Jayashree sent me the image. I was just on the mobile, I was just enlarging it, and now I am convinced that this is L4-5 prolapse disc, which is a big prolapse, very big prolapse. So
Hey,
Canada.
Gautam, I'm older than you, but look, even from such distance, I could magnify and see it.
Anyway, it is a very big prolapse, and now I'm sure that this is the recent onset L4-5. So this is the culprit most likely, and it is an extruded disc. It is an extruded disc. So here I'll be preferring straight away to go about the endoscopic discectomy, say without trying anything, because it is a very big disc. I don't know what is the canal diameter. Is it written there in the canal diameter in the report?
Can you go to the report?
Yes, sir. It's reduced at L4-5 as well as L5-S1.
Yeah,
around 7.
0.8, sir.
Yeah.
It is less than 1. That is true.
How
Less
much
than
was
10 centimeters.
Yeah, go to the
What was
0.7.
Yeah,
0.7.
0.7.
0.7. Okay, 0.7. So it is reduced definitely because transforaminal definitely can be tried. Transforaminal, the most important thing is here there is no this sensory deficits, no motor deficit around the L5 nerve root. Here the most likely is your L5. So that is not, there is no sensory motor deficits. So transforaminal definitely can be tried. But because of the looking at the very big herniation, the endoscopic discectomy can also be a very good important choice for this patient.
Yes, that is what I was hoping to get from the beginning. So, okay, so in terms of the foraminal compression, now the foraminal compression in this patient is pretty significant. Now, luckily, from what the history suggests, the symptom seems to be in the involved segments, she has only pain and a bit of tingling, if I'm right. So there is no numbness, there is no motor weakness in this segment, that is L5 and S1. So that being the case, we are justified in trying the minimally invasive, the lesser of the intervention. So left L5 selective nerve root injection is a good option. There is a role for endoscopic surgery in L4, L5 disc. Probably since the symptomatic side is more along left side, we can come in through the left L5 foramen for the endoscopic spine surgery. There is also a role for, if worst case scenario, there is also a role for open spine surgery at 4-5. Now, all of this, we are assuming that the patient for the previous, the L2, 3, L3, L4 lesion for which she is still having residual deficits, including anterior thigh numbness. We are not going to do anything. For hopefully the patient is sort of accepted with the previous thing. Any other any other treatment option any of the panelists would like to highlight? So we talked about left L5, we talked about endoscopic, we talked about open surgery. My final question, probably I'll ask Joyashree ma'am that if there is a role for a stimulator here. But before that, any of the panelists would like to think of any other intervention for this?
Sir, one more.
That's the only thing that it may address the pain on the left side. But what about the right side pain? So we have to consider that also in the management part, what we are thinking for that. If larger, not selective one, we are giving larger volume, which is also spreading on the other side. That is a different issue. But we have not talked anything to address
the right side pain seems to be more because of, not because of nerve impingement, just a disc degeneration, which is there in the MRI, where you are seeing a black disc at 4-5, can contribute to bilateral back pain. So probably
how to address that? Yeah.
Any other interventions before I ask Joyashree ma'am?
Yes, sir.
No, I agree with Dr. Jardhan that you can give a little bit larger volume. Earlier the paper and the experience was telling small amount of the local anesthetic steroid, but the recent ones and including our experiences, if you're giving a little bit larger volume, so what that will do, it will be washing off the inflammatory ingredients there, and also it will be taking care of the other side if you're giving a little larger volume. So a little bit larger volume also I will be suggesting. And one very important thing is the canal diameter. Canal diameter, anteroposterior canal diameter is also one of the very important indicator how much volume you can give. If the canal diameter is, the 7 millimeter or more, then there is no harm of doing an epidural also. So if you're giving a little bit larger volume, which can go on the other side or the other adjacent segments, that is not going to do any harm. In fact, that might be washing off inflammatory mediators.
This patient already had surgery. So if there is scar tissue, you're not going to try and do interlaminar or straight epidural. You can try transforaminal.
No, I'm talking about the transforaminal only. I'm talking transforaminal, a little bit larger volume, what Dr. Jardhan was telling, which might be covering the other side as well. That is what
But what you can do is, usually in this type of picture, if you treat the left side, the right side hurts. And you look at the MRI, there is some indentation on the right side too. My take on this matter would be just do bilateral L4, L5. So that way you're putting some amount of medication on both sides. And you
definitely that is an option. Definitely that is an option. Putting 2 needles on the other side and injecting on the both the side.
Yeah, and if you see that the approach may be difficult, there is too much scar tissue, you can do a caudal epidural with a catheter, where you can direct your catheter to the left as close as possible to left L4-5. You can pull back and inject on the right side, or you can keep it in the center. You get good spread with contrast. You can do a caudal epidural with a catheter. Okay, that's also an option, because here, if you are not that experienced or your radiology tech is not that great to give you a good view for the transforaminal with all these surgeries, you can try it that way too.
Yeah, so probably personally, I would have probably done a bilateral L5 nerve root for this patient. So bilateral L5 sounds actually logical to me as well. Joyashree ma'am, can I ask you, is there a role for a stimulator in this patient?
Before we go to stimulator, Karthik, I have one more point that I want to make. I want everybody to look at this person as an entire person and not to miss certain things. See, she has disc indentation in all her cervical, especially C4, C5 is very tight. Okay. And same way, even though
Aishwarya, can you put the MRI, please? Yeah, please go on, ma'am. Sorry.
C4, C5, the indentation is significant. Secondly, even though she had surgery, if you look at that L1 segment, there is so much reduction in the vertebral height, and there is still some, it looks to me like whether it is an old heel scar or there is some edema in that level. So don't forget that these things can also cause some amount of back pain, etc. Well, it is clear cut in this case that it was new onset, so we can try L4, L5. Definitely with this type of picture, if you tried 1 or 2 procedures and patient's mobility lifestyle is really cramped, spinal cord stimulator is an option. But she already had surgery with plates and screws in the thoracic region where you would attempt to place your lead. So you would have to get or try to place it higher than where your scar tissue is. So you may have to attempt to do it at T11, T12 to get your lead around T8 or T7 to cover the back and the legs. And secondly, if you have so much scar tissue, you can trial it with a percutaneous lead. But with this type of picture, if the lead placement during the trial is tough, maybe you should consider talking to your neurosurgical colleague for a paddle lead. Generally, I do not like to recommend paddle leads because then adjustments or revisions, everything gets difficult. But in this case, the main focus should be where is the scar tissue on the skin, and look at that segment between T12, L1. So, you know, your entry point has to be higher. That's all I want to say. Definitely, stimulator is a good option.
Right. So stimulator is an option, but considering previous spine surgery and considering the present symptoms, probably we should do something minimal. See, try that first, and if it doesn't work, we should think about the stimulator. Is Dr. Sneha with us? Dr. Sneha, I saw her in the name. I don't see her.
Yes, sir.
Yes, Sneha, I missed you in the beginning. So, in terms of technique, where people were talking about transforaminal and we talked about caudal as well. So, which would be your take? So, considering this lesion is coming only from 4 and 5 and L5 nerve root is involved, in terms of choice of epidural, which would you prefer? Would the transforaminal be better, or an interlaminar be better, or a caudal be better?
Transforaminal would be better, sir. Because a specific nerve root, when we are targeting, transforaminal would be the better option, I feel.
Right. So probably in terms of efficacy, probably the transforaminal is better than the caudal, and transforaminal and caudal are better than the interlaminar. Right. So probably that should be the way we should approach this patient. Try conservative treatment. If it doesn't work, which includes lifestyle changes, physical therapy.
Kartik,
Yeah.
Suppose if you are considering this particular patient, when the patient has visited a pain physician at 3 months, already tried all those drugs. So will you right now go to the interventions, or will you still try conservative management? 3 months history of this new onset pain.
I always like to try conservative management once by myself.
Okay. So what additional drugs will be adding here?
Sorry. So it's either gabapentin or pregabalin, tricycline, or duloxetine. So these are my options.
But already hasn't she received all these things?
No, sir. She received only NSAIDs, sir.
Only NSAID. Okay, definitely. But many times we get this kind of patient that this patient is already on the gabapentins, already on the muscle relaxant, already on the baclofen, already on the duloxetine. So in that situation, can't we go straight away for the interventions?
If she has tried this medication, if she has tried this medication, we should go for the intervention straight away. Yes, agree.
Kartik sir, I would like to add a point here. Before moving to spinal cord stimulation, after this diagnostic block, can we go for the pulse radio frequency ablation of this DRG thing if we are getting adequate good results from this L5 diagnostic nerve root block? So this can be
Yes.
because the power is quite okay with the lower limb, and we can also
Yes.
avoid surgery in this case.
Yes, Ravi is right. So if the first intervention probably should be selective nerve root injections or caudal. The second intervention can be the dorsal root ganglion L5 pulse radiofrequency. And if still doesn't work, we think about simulator. Ravi is right. You can add the pulse radiofrequency of the dorsal.
Yes, I
root
also
ganglion.
agree with Ravi. This is a very good point. That if
Hey,
the
Gautam.
if transforaminal patients is having good relief but early recurrence, pulse radiofrequency, though evidence is not that very good for the lumbar radicular pain, but still that can be an option.
Hey, Gautam and Ravi and
Yes.
Karthik. So I'm coming to practice with you guys in India because we don't get paid for pulse radio frequency here.
Get all your stimulators and come to India, man.
Yes.
Bring all your stimulators and come to India.
Okay, sure. Hey, one thing that I wanted to point out, like when you have a patient who had multiple issues, is still in pain. Yes, conservative treatment is an option, but then you have to bear in mind what I would tell all the youngsters is, it's not like there is something written in concrete, oh, I have to do gabapentin, or I have to do this, I cannot do this. You have to assess the patient's situation. How many doctors have they seen? How much pain they are in? What are they doing right now? How is she not able to function normally? You have to take all those factors into consideration. If somebody is watching a Yup TV or Sony TV and changing the remote, and they are having pain, yes, go ahead, give them gabapentin, do some conservative management. But if it is somebody who has 4 children, she's working too, then maybe you might want to give her the injection plus the gabapentin and then take it from there. So what I mean to say is, yes, these are the guidelines or protocols that you follow for yourself, but you have to assess your patient and address the need of the patient. Over to you.
Yes, accepted. So that is acceptable. I think we have a solution. So we discussed various differential diagnosis, and we also discussed various interventions. I think totally we got a good result. Anything else any of the panelists would like to add, or any of the delegates, if you want to ask us a question, we are happy. Put it in the chat box, please.
Or any comments directly from any of the audience who are there participating.
Regarding DRG, I would like to mention one thing, DRG pulse RF. Though it is considered totally harmless pulse RF in the clinical practice, but there are reported cases where the harm has been done. So when we are planning to do, one has to mention about the possible risk of injury to the root also, DRG2 also. And my practice also in the early days, one patient developed numbness, very long lasting numbness in the foot, which like recovered after a lot of B complex injections, and it took almost 3 months to come to the normal. So this possibility, though it is very, very, very rare, but when I searched the literature, I have found, though it is said that 42-degree temperature remain the same, but there are spikes of the sparks which can happen and then can cause the neuronal damage. So this is just one line I want to say. And of course, technically evidence is also very poor, but this is one of the conservative, so-called the minimally invasive thing which we can adopt going for this, before going for the surgery.
Thank you, sir. Dr. Asha has asked if we should do anything for the facets, but yeah, facets in the MRI seems to be affected, but the clinical pattern seems to be more of radicular pain. You can see the pain pattern is radiating below the knee as well. So probably we should do the nerve root first and see, and if they get good results, that's fine. In spite of it, if they have any pain, we should consider the facets subsequently, not probably the first time. I hope that answers your question, Dr. Asha.
Yeah, some of these patients, once you do the transforaminal, they'll come back to you and say, oh, leg pain is gone, only my back is hurting. And then you assess if the facet needs to be addressed. That will be your next step.
Any other comments, doubts?
Sir, I have a question.
Yes, please.
So, any role of ozone discectomy in this patient?
Not really.
Actually, I was also going to tell these things. So ozone necrolysis, there is, and when there is good hydration, because ozone causes the the dehydration, shrinkage of the disc by the dehydration. But if the hydration is not good, then ozone is going to fail. So ozone can be a good option in certain situations, but here in this particular case, I don't think ozone is a good option.
Thank you, sir.
Any other questions? Right. So great job, Aishwarya. So I actually previous delegates itself, I wanted to ask them to put a pain map so it becomes easy. So today you put beautiful pain map. So good job, Dr. Aishwarya and the other speaker. So thank you, panelists. So this case, pretty obviously, the diagnosis was reasonably clear. So I think most of you who followed it must have got the diagnosis. So conservative management first, basic interventions next, and if it doesn't work, think about advanced intervention. So in this patient, L5 selective nerve root is the intervention of choice. Most of the panelists are agreeing to that. So thank you very much. Anybody else would like to point anything else?
Sir, I have another question, sir.
Yes, Dr. Ranajit.
Side effect of ozone therapy in ozone nucleolysis. Some of the spine surgeon, especially neurosurgeon, they said ozone is very harmful to the discs. Please enlighten this point, sir.
So at this point of time, we don't have conclusive proof to show that ozone nucleolysis works for intradiscal usage. Now, if you see, go back to the history, the ozone nucleolysis was a procedure which was meant for well-contained disc of recent origin with nerve impingement. Now, the rationale of using ozone, the hypothesis, it's not an accepted rationale. The hypothesis was the ozone was breaking the bond that was there, forming between the proteoglycans and the water, thereby causing a process like similar to mummification of the disc. So this was shrinking the disc down. So probably the people who have been practicing for some time, the seniors, we all know that we started ozone discectomy in India somewhere around 2005-ish or somewhere around that time. By the time of 2010 or 2015, in India alone, we must have done at least, if I'm right, 30,000, 40,000 ozone nucleolysis. Now, subsequently, what we found was most of the time when we did this procedure, we never did this standalone. We did this, and along with this, we also did the selective nerve root. But we never had any harm in terms of very few cases where there was discitis or something with ozone. But we, in spite of a lot of
not only that, Karthik, there are lots of publications are there also in the interdiscal ozone. So interdiscal is ozone doing harm. Still now there is no evidence there also in the literature that it is going to harm. But of course, the way ozone nucleolysis was done in the initial period, what Karthik was telling, later on doing the ozone nucleolysis by the pain physician has reduced considerably, looking at the failures, and we started thinking that, okay, why there are failures, whether at all this should be done or not. And then subsequent papers and our experiences, and if you're looking at the mechanisms, it should be very selective on what Dr. Karthik already told. Recent, where the hydration of the disc is very good, and minimally either contained or very minimal leakage. This kind of selective cases also should do. But forget about what people are telling. Ultimately, everything has to be proved by literature. Whether literature is telling that, okay, interdiscal ozone is harmful, I am not sure about any such publications.
Right. I hope that.
Whereas we have seen lots of publications on the interdiscal ozone. Okay, I think very good discussions and no more points to discuss. So again, thank you all the panelists for sparing their valuable time, particularly Karthik, week after week, and many other like Jayashree, the Oscar Jordan, Ravi, many others are. Sometimes I rotate on going on panelists, but sometimes few panelists are almost there constantly. So thank you very much. But what I was surprised looking about the number of participants. So what I was thinking that instead of doing it every week, maybe we'll be doing it once in a month or twice in a month. So what we'll be doing, we'll be putting it in our different groups that when will be the next one. And of course, it is not going to be stopped. It will be going to be less frequent. And when the demand will be more, we might be increasing the frequency as well. But this will continue because it is, many of the junior pain physicians has told me that they are immensely benefited with this kind of different types of case scenarios. Like today, both the case scenario was very good and I should say very common. And particularly the second one, which was, earlier surgery, earlier fractures had confused the whole scenario. And in practice, we really going to get this kind of case, not just straightforward case. That is the clinical practice where, nothing is very straightforward. So this kind of things is definitely going to enlighten us further. And thank you, Karthik and Debjyoti, for excellent moderation, and thank all the panelists for sparing their times and joining these case scenarios. So thank you very much, and thank you very much, Karthik, again.
Thank you.
Thank you, sir.
Thank you to all the panelists.
Bye-bye.
Thank you. Thank you
sir.
very much.
Thank
Bye.
you so much,
Thank you.
sir.
Thank you,
Bye-bye.
sir. Thank you. Thank you, Dharadhya.
Thank you. Thank you.